In the UK, we have had a particular problem with nursing homes and long-term care facilities. And there's been a lot of ethical issues around isolation in nursing homes. But what I'd like to look at is what we've done in terms of our nurse education programs throughout the coronavirus, and to share some of our experiences, if you like. So a little bit of, we start off talking a little bit about initial nurse training, pre-registration nurse preparation. And then at the end, I'll talk a little bit about our post-qualifying education programs that we've been running through the pandemic. So in nursing in normal times in the UK, we have regulation of nurse education is by the Nursing and Midwifery Council. And it's not a professional association like the ANA or the Japan Nursing Association. This is a government agency set up to regulate nursing. It runs the register and it sets the standards of initial nurse training. And all nursing in the UK has to be a minimum of 4,600 hours over at least 3 years and a minimum of 2,300 hours of clinical practice. And now those programs are delivered by approved educational institutions, approved by the Nursing and Midwifery Council. In Wales, we're fortunate we are now at an all-graduate profession. So every nurse training and qualifying has done a degree in nursing. So we have one level nursing, registered nurse, and everybody is trained through university education now, which is a great step forward, but also causes some problems for us over the last few months. Other key stakeholders, well, the Welsh Government, now health and education are devolved in the United Kingdom to one of the 4 nations of the United Kingdom. So Wales has complete control over nurse education and health, and the position in Wales is that the Welsh Government, the executive if you like, commissions universities to provide nurse training. So nurse education is paid for by the Welsh Government. The students receive a small training bursary, so a small income, and their fees are paid for by the Welsh Government. And that cost comes from the general health services budget. So obviously the Welsh Government think that they own the student nurses because they pay for them as well. We then have the National Health Service, which in the United Kingdom provides, I would say, it provides 100% of acute care and maybe 60-70% of other care. Its care is free at the point of delivery. It's comprehensive and universal, covers everything from minor injuries, family doctors, all the way through to organ transplants, all the way through to living with diabetes for 20, 30 years. All of that care will be provided free and paid for by general taxation. So the National Health Service in the UK has been the prime responder to the coronavirus outbreak. And we work closely. So basically, one way that people think of us in the university is that we are a training institution for the health service, which is like one way of thinking of it. But we are an independent set of universities with our own training programs. So the universities then are the final stakeholder, and we'll come back to those maybe later on because of the complexity of working with universities. And then very important stakeholder is our students as well. So our students come into nurse training with expectations. They expect to learn, they expect to be safe, and they expect to progress through their studies. Now, the coronavirus came along and threw on top of them lots of novel events that they didn't sign up for. And this is a common thing we heard from students. I didn't sign up for this. I didn't sign up for working in the pandemic. So they didn't sign up to be a low-paid workforce. They didn't sign up to be put at risk. And so we had a lot of trouble managing students who were anxious, overwhelmed, and angry sometimes. that they felt that they were being abused, and that their position as a student was being abused, that they were just being used as a pair of hands when they should be a university student. And so we saw a lot of emotional and also cognitive costs. And the cognitive costs really came in the form of cognitive disengagement. They just couldn't keep up with everything, especially at the beginning when there was so much information, so many changes to the nursing programs, their nursing placements, and so much support being offered by so many different people. They were just overwhelmed and they just switched off. We continued to deliver practice-based education. Now, all our year one students, we removed from practice in March 2020. We did that for two reasons. First off, they're only very, very junior in their nursing careers. So they can't offer much in the clinical placement in terms of being helpful. They also require a large amount of supervision. So we removed our year one students to remove that burden from our clinical placements, clinical wards, district nursing teams, family doctors, etc. So that they wouldn't have to be looking after coronavirus patients and looking after year one student nurses who didn't really know what they were doing and could be dangerous, especially around infection control and so on. Now, obviously that makes a problem because the years on placement in year one, or the hours on placement in year one, contribute to their total hours for their nurse training. So we've got problems straight away with an unbalanced curriculum. Now, our year two students and our year three students who were in the first half of their final year, they went on to extended placements. They were given a choice. They could do a pure theory, so they could completely opt out of clinical placement if they thought they were at risk, or they thought that they had family at risk. They could choose not to go to placement. Those who stayed in clinical placement, they shifted from a program that was 50% theory, 50% practice to one that was 80% practice. Now that means that if you do the calculations, their theoretical content shrank by 60%. So they were only receiving 40% of the theoretical content of their program, and that spare space in the curriculum was taken up with clinical work. And this was so that our nursing students with some experience could make a positive contribution to the health service at time of crisis. Our year three students who are in the last 6 months, they are always counted as part of the workforce. They're not supernumerary, and they deliver service as part of their training, and they continue to do that. But that was problematic because they have to do certain leadership and management competencies at the end of their nurse training, and that was difficult for them to achieve on wards that were very busy with very sick patients, and it was difficult for them, but they stayed in placement at the last 6 months. Okay, so what difficulties did we have with our practice-based education? First off, risk assessment of students. We had to risk assess every student to see, did they have asthma, did they have diabetes, were there underlying health conditions, were they on immunosuppressive therapy? So we had to risk assess, and we have over 1,000 student nurses. So we had to risk assess 1,000 student nurses. We had to make the decision whether they would actually be an asset to the health service or whether they would be a burden because of inexperience and needing supervision, possibly making mistakes. We had problems with their supervision in practice and providing quality learning environments. A lot of people would just throw their hands up and say, surely we can just forget about nurse training in the middle of a pandemic. But the reality is we still need nurses qualified at the end of the program. And this was pointed out by Stefan in terms of nursing shortfall. We still needed a throughput of nurses having their training so that they could qualify. And we couldn't just put the whole of nursing education on pause for an indefinite amount of time. So we had problems with supervision and providing clinical mentors and clinical assessors. We had problems with the wards were changing what services they provided, and so we audit and do an educational approval of every clinical placement, and those are now redundant, because what was previously obstetrics and gynecology was now respiratory care. What had been trauma and orthopedics was now female surgery. And so we saw a lot of changes, and it was difficult to ensure educational quality in practice placements. We also found that some placements had no clinical work. Elective surgery was cancelled, and so students on placements that relied on elective surgery like orthopedics, they had no patients. Other wards like respiratory care were overwhelmed. So we had students had very unequal experiences, and there was a real worry that it would be work but no learning, and they wouldn't actually be achieving any competencies or achievements through their placements. We also had a problem with year 2 students and year 3 students who opted out of the extended clinical placement, and they said, I'm too much at risk, I don't want to do it, I'm too scared. And we said, that's fine, you can opt out. We had problems then of cohesion in the group, because there were people who'd done it and they felt that they were heroes and that they contributed, and they were very, very negative towards people who had opted out, saying that they were too fearful, they were too scared, that they should have shown some courage, and that and so there was a lot of, within the group, the student groups, a lot of problems, friction between different groups of students.